Okay, we will get it started. Welcome everyone to tonight's webinar, update on aortic stenosis. We are joined tonight by presenters Associate Professor Caleb Asrus and Natasha Finkel. My name is Serena and I'm your ICGP representative for this evening. This education has been developed in partnership with Macquarie University Hospital, which they are sponsored by Medtronic. Before we get started, I would like to make an acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online tonight. I'm joined on Gadigal land, located in Sydney. I would like to formally introduce you to our presenters for this evening. Associate Professor Caleb is a consultant and interventional cardiologist at Macquarie University Hospital, St. George and Central Private Hospitals, as well as Bankstown Hospital, where he is the director of the Cardiac Catheter Laboratory, interventional cardiologist at Liverpool Hospital, and clinical associate professor at Macquarie University. He leads a busy clinic program and active research group dedicated to improving patient care and outcomes. Also joining us is Natasha, is a GP from Sydney who has recently moved to Gold Coast and works for a specialist women health clinic where she has special interest in chronic disease management. She's committed to quality medical education of junior doctors and worked for many years as a lecturer at the University of Notre Dame School of Medicine. Welcome to all our speakers. I will now hand it over to Natasha, who will then go over the learning objectives.
Thank you so much, Serena. It's wonderful to be here tonight with our esteemed cardiology colleague, Associate Professor Caleb Asrus. Our learning objectives for tonight will be to, number one, outline the epidemiology of aortic stenosis. Number two, identify clinical signs and symptoms of aortic stenosis. Number three, summarize how to perform a rapid cardiovascular exam in primary care. I like to focus on rapid. That's very important for us in general practice. Identify when to refer patients to an interventional cardiologist, and outline the importance of a heart team in the multidisciplinary care of patients with aortic stenosis. So we're going to be specialists at aortic stenosis after tonight, thanks to Professor Asrus. Moving on, and I can hand that over to you, Professor Asrus.
Thank you so much for the opportunity to discuss this really important topic. I'm hoping you can all see my slides. Natasha, can you confirm you can see the slides? Fantastic. Yeah, and particularly Medtronic for supporting this, and Macquarie University Hospital and Bernadette for a lot of the energy behind this, and of course Serena and Natasha for facilitating this. So this is an update on aortic stenosis. We've spoken about the objectives. I don't have any financial disclosures relevant to this presentation. And I think as a sort of to lay the I guess the background and really give you an idea about sort of the issue at hand is actually the prevalence of valvular heart disease in general. So we are going to talk about aortic stenosis, but as you can see, there's 4 valves in the heart. I mean, we're predominantly out of the congenital realm interested in the aortic, mitral, and tricuspid valves. And you can see as the with the aging population, you can see that actually aortic stenosis, mitral regurgitation, and particularly tricuspid regurgitation is going to be a big issue. And luckily, obviously, with the aging population, surgical pathways of open heart surgery are not necessarily ideal. So we do have actually robust evidence-based therapies that are transcatheter-based, keyhole-based, doing procedures even with patients awake to address all these 3 valves. So, so it's fantastic to talk about aortic stenosis, but actually a lot of the assessment and obviously being at the front line of healthcare in general practice, I think we've got to be aware that it's not just one valve. We've got to be thinking about everything else, and these are things we can deal with day to day. So back to severe aortic stenosis. So this is obviously very, very common, and this is quite a nice scheme. Essentially, if patients start developing symptoms, this is exactly where the danger signs are. So this is sort of patient survival based on symptoms. You can see people just falling off the cliff. So if patients are presenting with angina, syncope, heart failure symptoms, breathlessness, so on, and they have a murmur, we've got to suspect that there may be a valvular problem at hand. And if we're not addressing it, this is the risk. And the most common presentation is sudden death. So the lucky ones may present with heart failure and so on, but there is a yearly risk of these patients. So you can imagine the problem. And actually, this is sort of highlighted even further. If you look at sort of inoperable cancers, this is 5 years survival of all these things that we sort of obviously worry about and very important. But if you look at inoperable severe aortic stenosis, the 5-year survival is 3%. So this is what we're trying to prevent. And actually, there's very, in terms of the therapies, and hopefully you'll be convinced by the end that actually we have some really fantastic treatment options. But if patients are not diagnosed, then that's a problem. But I think it's really important sort of to highlight that this is a really malignant process that we need to sort of address. Essentially, just a brief outline of a normal valve on the left. So it's often trileaflet. So in younger patients that present with stenosis, it can be bicuspid, and they can have an accelerated pathway of calcification. And you can see that the next one is a bit of thickening, calcification. We won't go through the pathophysiology. It's complex and actually poorly understood, I have to say. And you get to severe aortic stenosis, where the orifice of the aortic valve is small. The left ventricle is working very hard to obviously allow passage or push sort of the blood through and so on. And you can see that particularly on exertion, patients can get presyncopal. They can get heart failure symptoms with sort of pump failure, pulmonary hypertension, and other things. So this is sort of the scheme, and most of our patients in the sort of moderate to severe range, in their sort of 70s, sometimes in their 60s, and beyond. So this is, quite an interesting observation from the National Echo Database. We're very lucky that we've actually got the biggest echo database in the world in Australia. So it's based out of Royal Prince Alfred Hospital, and it's called the National Echo Database. And this could extrapolate sort of the population that we're dealing with. So it's not a trivial problem. So we're almost approaching 100,000 patients affected Australia-wide. By 2031, we're going to look at sort of more like 200,000. So this is a doubling with the aging population and so on. So around 4% of patients in their sort of early 70s, and over 8%, approaching 10% of 80-year-olds have moderate severe aortic stenosis. So it's not. So if you think about the number of 70 and 80-year-olds we're seeing day to day, a lot of them may be asymptomatic, or they're not quite got. So we'll go through the symptoms anyway. But a lot of these patients are out there. So I think that's, again, that's why it's so important to really think about this and assess these patients and allow them sort of to go down the treatment pathways. So in terms of the symptoms, this is, we talked briefly about this. So we're talking about chest pain or chest tightness, reduced physical activity, palpitation, shortness of breath, feeling that you're actually just slowing down. I mean, if you think about these symptoms, a lot of them are fairly innocuous, particularly the reduced exercise activity. In an 80-year-old, they might be thinking, well, this is just the age, wear and tear, and so on. So they're fairly, obviously, the sort of chest pain, chest tightness, we are sort of used to sort of working up these kind of patients. But because it's progressive, a lot of patients do actually modify their activities and may actually be not very forthcoming with their symptoms. In terms of actually risk factors for developing aortic stenosis, of course, advancing age, you've seen things like hypertension, diabetes, smoking, connective tissue diseases, inflammation, autoimmune disease, and so on. All of these can actually accelerate calcification of the valves. So things like chronic kidney disease, coronary artery disease, and so on. So unfortunately, in terms of actually, there's been lots of studies done in the past on statins and various sort of potential disease modifying agents, but nothing's actually been shown to slow down or prevent or reverse sort of that pathway. So all we're left with is obviously treating some of the symptoms, so the heart failure symptoms, and also the mechanical therapies of actually fixing the valve. So my key takeaway, and I think from a general practice point of view, is that we should suspect aortic stenosis and generally valvular heart disease anyway in this patient population. We're going to listen to the patients at auscultation. These are things that we've been doing for years and years, and I'll hopefully show you that it's not actually that difficult, and we will hopefully try and demystify that. And once you listen and you do hear a murmur, then think about referring the patient to a specialist with specialist expertise in this area. So what I'm going to do is just show you a brief video of what I may actually do in the clinic. I mean, COVID's actually been very good in some ways, in that we've actually got used to rapidly assessing patients, minimizing contacts, and actually these are some of the things that we've actually retained. So in my clinic, this is exactly how I would actually assess a patient, with a few caveats. But this is, as you can see, very easily implemented in the surgery. Very, very busy practice and so on, and we're sort of we're there with you in spirit, certainly. So we'll just let this play, and hopefully all your volumes are up.
A cardiovascular examination fit for primary care. COVID's actually shown us a lot about minimizing sort of contact, but actually routinely now I'd actually examine all my patients in the chair, and you can see that this can be done quite quickly and quite efficiently. Key thing, I guess, with a cardiovascular examination is that we do want to measure blood pressure, we want to measure a pulse, which we'll do now, and auscultation. So those would be the three things that I would do routinely. So Christopher, I'd like to feel your pulse, please. Thank you. So essentially I'm trying to measure the pulse rate, if it's going fast or slow. I don't necessarily actually would accurately measure it in terms of time, but is it irregular? Are there any misbeats? Obviously I'm also feeling for sort of peripheral perfusion. Okay, thank you. And just look up for me. So I'm just checking for conjunctival pallor, any icterus. Open your mouth for me, stick your tongue out. So assessing fluid status, and close. And then I would auscultate. And what I'd recommend doing is just listening for the two sounds, first and second heart sound, and see if there's any murmurs. I wouldn't necessarily worry about timing. Is it ejection systolic? Is it pan-systolic, and so on? Can you hear a murmur? If you can hear a murmur, that's all we need to detect. And then the rest, that should precipitate, thinking about the next investigation, which should be usually a referral or even an echocardiogram. Okay, so just sit forward for me, Chris. So percussion. Big breath in, out, again, and again. Keep going. And again. And again. Beautiful. And the only other thing I would do is actually just check for any peripheral edema. So any swelling in the ankles here, just on one side, and that's it, nothing there. So hopefully that shows you, obviously even with commentary and discussions, that can all be done in just a...
So I'll just stop there, and I think you can see that actually that was actually the video is just over 2 minutes. I would routinely do essentially like this in about a minute. So if you do it routinely in your patients, hopefully it's not as complicated as we may remember for our finals exams and so on. And hopefully we can just, and the more you do, the more you listen, the more you'll be able to sort of discover that actually a lot of people do have murmurs, and we're not sort of looking for sort of academic sort of honors type examinations, but so keep it simple, keep it regular, keep doing it, keep practicing it, and if you hear anything, we're here to help and treat the patients as necessary. So I may just sort of stop there. If Natasha, you've got any pressing questions about the examination, I think it's quite important to sort of go through this.
Well, I was really happy when you said, is there just a murmur there? That's all we need to find, because that's, going back to the panic in medical school, we're trying to figure out which type of murmur it is. It's nice to hear that we can simplify it and refer on when we need to. There aren't any other questions in the chat box, but if anybody does have anything that they want to ask, I'm happy to pass that on, but we can keep moving on if that's okay. Oh, sorry, there's one question. When you find a murmur, but there are not yet any symptoms, do you do an echocardiogram?
Good question. So there is, I think the key thing is that, yes, we would do an echocardiogram. There's a lot of asymptomatic patients that we pick up much earlier in the piece, and then we may plan to follow them up depending on their severity. There's a lot of patients actually that present in quite severe stages that just don't admit to any symptoms. And some of that actually could be quite sort of high risk. So if you detect a murmur, that could be mild, moderate aortic stenosis. There may be other things, mitral regurgitation, other things. We would usually just plug them into annual surveillance, depending on the severity, or every 2 yearly, or we may say just come back in 5 years and for an echocardiogram. So we would. I mean, this is exactly when we actually want to see patients early. We don't want them. I mean, we work in the hospitals, and patients come in with heart failure symptoms, progressive sort of issues, and obviously they're much more difficult to deal with down the track. So, so we would, on the point of, there's a whole approach, and there's lots of studies in asymptomatic patients with severe aortic stenosis, because a lot of the data was actually on symptomatic patients. So it's like what I would do routinely, and it's, as per the European guidelines, actually, I would actually just do a stress test. So I'd put them on the treadmill, and you'd be surprised, over 80% of a patient will get symptoms. So they'll drop their blood pressure, which is a really bad sign. They'll get breathless, they'll get pre-syncopal, and then that's obviously supervised by a specialist and so on. So and then that actually often proves to the point to us, to the patient, and their sort of healthcare professionals, that actually they do have symptoms and they can go down the path. But I do have a lot of patients that I survey that have quite high gradients, but actually are truly asymptomatic. They're still doing all their daily things, they're dancing, they're swimming, and so on. So we're happy to sort of keep them under surveillance, but we may keep a closer eye on them.
And this is on that same point. We have a question that asks, are there any features, particularly on examination, that point to the severity of aortic stenosis?
Yes and no. So often, generally, the louder the murmur, usually the more severe, unless it's actually very severe and the cardiac output has actually dropped, so that the heart started failing, and actually you can get much quieter. So normally with aortic stenosis, you get a loud ejection systolic murmur that you can hear throughout the precordium or the chest, and you get a quiet second heart sound. You'll also feel peripheral signs of a slow heart, slow pulse pressure, slow rising, and that usually sort of in the carotid or peripherally. But there's lots of other peripheral signs. So I wouldn't sort of necessarily be hung up on, and the diagnostics is so good at the now that actually that we some patients you can hardly hear a murmur, but their valve is hanging on for dear life. So I think, of course, as you examine more patients, as you may have referred them on, and we may say, look, can we see them in a couple of years? Then, of course, you may see them more regularly and keep an eye on the murmur and so on. But generally, that's not that helpful in seeing disease progression. Generally, because it will change on depending on your sort of fluid status. You may have an infection, thyroid issues, high output states. So all these things will change the character of the murmur. But actually, if you keep a close eye and they start getting symptoms, that's the key thing.
Great, thank you. There aren't any more questions, so we probably could move on to the next slides.
Fantastic. So we've gone through that. So in terms of actually what happens to the patient, so you've heard a murmur, that they get referred to me or one of my colleagues. We would usually do an echocardiogram. We would see them physically, often with their families, and they've either got significant disease and symptoms, and then we go down a path of working them up for intervention. We'll go through sort of the management options, and depending on they may, if they're quite old and frail, we may do a frailty assessment. This goes through actually the kind of people that see patients that form part of the multidisciplinary heart team. They would get transthoracic echocardiogram, as we said. They may have a coronary angiogram to make sure that they don't have concomitant coronary artery disease. So, of course, that might dictate how we treat them, whether it's stents, coronary artery bypass grafting, as well as sort of the aortic valve intervention. And they'd often get a multi-slice computed tomography, so multi-slice CT, that will tell us about their peripheral vasculature. And I've got examples of this. See if a transfemoral approach for a transcatheter procedure is appropriate, and also the sizing of the valve, if there's any hostile anatomy of the valve, the heart, the approach. Obviously, we're trying to reduce all sort of the complications. Once we've done all of this or part of this, they would actually be seen by, they need to be seen by cardiologists, and most of our patients will be seen by a cardiac surgeon as well. That's part of sort of the governance process for Medicare. And they'll also see an aged care physician who will assess their frailty, their cognitive function, and quite in a lot of detail and lots of sort of, and obviously see them physically as well. A lot of them may get a 6-minute walk test and so on. Of course, if they're a young patient that's actually pretty intact, then they may not need that. But actually, a lot of thought goes into the patient journey. And then the treatment options. So there's essentially 3 treatment options. If the patient has got severe symptoms, severe aortic stenosis, the treatment options are, they may be too frail and are inoperable because of comorbidities and other things. And unfortunately, the outcome, as we've shown in one of the early slides, is pretty poor, and then leaves us, and there are some patients that are sort of appropriate for that. And then it leaves us with open heart surgery, and we'll go through that here. So this has been around for many years. So Hufnagel, who's a specialist from Washington, actually implanted the first surgical aortic valve in 1952. So we're talking, over 70 years of progress. And you'd be amazed the sort of transition to what we can do now from a surgical point of view. So this is something we've been doing for a long time. We get our surgeons, so our cardiac surgeons get excellent outcomes. The prostheses and mechanical valves and particularly bioprosthetic valves have come on a long way in terms of their durability and so on. So this is in the right patient. This is an excellent operation. Obviously, we looked at sort of the outcomes if we leave things alone, but actually this is patients do very well after one of these procedures. And then the alternative, so this has been around obviously for about 70 years, very mature, but the pioneering concept that arose from a Danish specialist, Henry Root Andersen. So he had a fantastic animal facility, and where they developed sort of this type of valve in his kitchen essentially, and he implanted it in 8 pigs and published this seminal paper in 1992 in the European Heart Journal that showed actually that these animals survived, so that he actually implanted above the actual native aortic valve. And that was a proof concept, and that was sort of submitted to patents and other things. And then it was 10 years later that actually another pioneering specialist, Alain Cribier, in 2002, had an extremely frail, very sick patient where there were no surgical options, and he implanted the first valve. Unfortunately, Alain Cribier is a fantastic colleague, and I've met him many times, and a supporter of. So he passed away earlier this year, but he's been a real giant of our sort of field. But he sort of pioneered the first procedure, and from there things have moved on. I mean, there's been multiple randomized studies, but we went from 2002, the first TAVI, to the first randomized study. So this is, you can imagine, obviously surgical pathways are very mature, but we started treating our extremely high-risk patients, so the patients that could not be operated on, and they were randomized to a transcatheter approach, a transcatheter aortic valve implantation, or just optimal medical therapy. So, with the outcomes that we saw. So at 1 year, there's a huge difference there's an absolute risk reduction of 40% in mortality. So 40% more patients were alive at 1 year in a randomized study. So this is one of the biggest advances in medicine, certainly in cardiovascular medicine. And this moved on to high-risk patients that could be operated on, but actually So they're randomized to surgery versus a transcatheter approach. That's back in 2011, and then that's moved on to lots and lots of other studies in a lower risk group, in the intermediate and what we call low risk group. And all of these have been done, and there's actually more since then. So we won't go through all those. We'll definitely put everyone to sleep this evening. But a nice meta-analysis for a few years ago actually summarizes the outcome. So, we worry about mortality, so all-cause mortality. So if you look at this forest plot, so the left favors TAVI and the right favors surgical aortic valve replacement. So in the high-risk patients, intermediate risk patients, and the low-risk patients, mortality significantly favors TAVI. So more of our patients are surviving, and this is across sort of 5 years beyond, and a lot of these sort of studies have continued to follow up the patients. And in terms of the actual, we're talking about a 70-year mature procedure, surgical aortic valve replacement, but the transcatheter approach has a significant mortality benefit in the short to medium term. If you look at stroke, obviously this is very emotive, and actually most of our patients are very happy to die, but they don't want to have strokes. So if you look at the stroke rates, again, this favors TAVI to the left, and that's significant. And this is obviously when we talk to our patients, we sort of consult them on this. This is something we don't do as well, pacemaker implantation. So obviously the aortic valve is very close to the intrinsic pacemaker centers of the heart. So our pacemaker rates are higher. Some of it's sort of technical, and actually we've reduced our rates. So in a TAVI population, we're talking about 8 to 10% of our patients, and I consent my patients for 10% may need a pacemaker. There may be underlying conduction tissue disease that might increase the risk of that. With surgery, we're looking at 3 to 5%, but that's something that we discuss. We won't go through. There's multiple other endpoints. Most of them actually do favor the TAVI. So, in terms of a cardiovascular death, myocardial infarction, acute kidney injury, atrial fibrillation, that is very common post-surgery. All of these favor a minimally invasive approach, and vascular complications, obviously we are going through a vasculature, not through the sternum, does favor a surgical approach. Just depends on how you sort of assess it.
Caleb, there's a question from the audience. Does early treatment and surgical valve replacement reduce the cardiovascular risk and mortality? So maybe on having the intervention earlier rather than later?
Good question. I think if they're symptomatic, that's the right time to do it. So as I'll show you later on, there is a lifespan to the valves that we replace. So if you get, and generally what we advise is with a surgical aortic valve, we normally traditionally say 10 to 12 years. And we didn't have the data, and I will show you some data a bit later on. We say about the same for a transcatheter valve, so 10 to 12 years. So if you intervene earlier, you don't necessarily get, obviously you're going to mitigate against the risk if they're symptomatic, and if they're symptomatic, you need to intervene, whichever way you want to sort of go through it. But it's not, if they're asymptomatic, then you shouldn't. But everything's got a shelf life of 10 to 12 years. Hopefully in the future, then that things will improve. But when we look at the lower risk patients in their 60s and even sort of beyond, we'll go through sort of the approach for age. We actually talk about lifetime planning. So if somebody's going to survive, 20, 30 years, then we need to plan our procedures. So essentially, and this, I think it's a great question, but essentially, if you have a surgical replacement, we can actually put a TAVI valve inside the surgical replacement. If you have a TAVI valve that starts failing, sort of 10, 12 years, maybe sometimes earlier, you can actually still put another TAVI valve inside that one, and you can get very good outcomes with a minimally invasive approach. So that's the two options. A third procedure becomes difficult. So you can't do 3 TAVIs in a row. So if you're thinking somebody's going to survive 3 procedures, we're talking, over 30 years. So 60-year-old that might, is long lived in terms of their family and so on, then you would probably, and what I would advise is actually that one of the first 2 procedures should be the open procedure. So maybe a robust, still working early 60-year-old may actually decide to have a transcatheter approach because they can continue, and maybe in the early 70s they have the surgical approach, and then you can do a valve-in-valve transcatheter valve down the track. So there's the shelf life, and in terms, I think that sort of gets us quite nicely into this next slide in terms of how we manage the patients and maybe we can sort of fast for this actually, from Heath Adams, a good colleague of mine. He is in Hobart and has a fantastic program there. So they've sort of published this in our general practice journal. So if you look at so obviously the patients are diagnosed, they've got symptoms, they've got aortic stenosis, they're assessed by a heart team. So if the valve and vascular anatomy is suitable for transfemoral TAVI, then you've got options. If they are actually have a lot of comorbidities and are poor functional status and frail, then medical therapy or palliative care is a pathway that we will still have discussion with our patients and families. But if we concentrate on the left side, and this is adopted from a lot of the international guidance, particularly the American guidelines from 2020, that actually below 65, and that's sort of from the lifetime planning piece, then we would favor surgical aortic valve replacement. Above 80, we would favor a transcatheter approach, so TAVI, and between 65 and 80, there's equipoise, and the recommendation is to be shared decision making. And having been here a long time, everyone in that age group wants a transcatheter approach. There's no one that wants actually a surgical pathway at that age. So generally, anyone sort of 65 and above, we are considering for TAVI as a first sort of first line therapy. But certainly in terms of the international guidelines, it's a class 1 indication to perform either a TAVI or a surgical aortic valve replacement in those patients at 65 to 80. The ones above 80, it's class 1 indication to perform TAVI. And it's a 2A recommendation to perform surgical aortic valve replacement in an over 80-year-old, but below 65. And this is, we have these discussions, and the heart team involves colleagues that specialize in the surgical approach, but also perform the TAVIs with us. So the heart team is actually very agnostic of actually what we're going to do. So we try to get the right outcome for the patient. But 61, 62-year-olds coming to us wanting a TAVI, we have to sort of gently sort of persuade them that may not be the right thing for them over sort of a lifetime period. Hopefully that's addressed that, Natasha, but I'm happy to sort of go into a bit more detail if there's other questions, because I think it's important.
Yeah, no, I think that was a great answer. There was a question about asymptomatic patients that have severe disease and their risks of sudden cardiac death or other risks associated with that, more in the asymptomatic patient.
Yeah. So the short answer is there's no current evidence and guidance other than actually assessing them from a exercise stress test point of view, and where you actually can demonstrate some studies. So there are some ongoing studies where you're actually randomizing studies. There's a couple on the horizon. In fact, there's a couple of ones actually in Australia. Easy AS, aortic stenosis is a good one that's recruiting currently. So essentially, I mean, from a pathophysiological point of view, these patients have aortic stenosis, but they've also got concomitant left ventricular hypertrophy. They've got myocardial scar. They may have conduction tissue disease and so on. So there's obviously a mechanical issue that might put them at risk from sudden death, but there may also be a scar-related tachyarrhythmia that they're at risk from. So there's a lot of work being done in terms of strain imaging and exercise sort of imaging, cardiac MRI, and so on, to try and risk stratify these patients. I would say in my practice, this is actually, I would say, perhaps in the severe range that don't necessarily have any symptoms. We're talking maybe 5% of our patients, maybe even less. So most of our patients fall into a classical symptomatic aortic stenotic patient, or that they're asymptomatic but actually proven that they do have symptoms, or at least some hemodynamic insult with that. But actually that also speaks to, I guess, diagnosis and primary care. So the patients are not being they're not volunteering any symptoms, so they're not being necessarily assessed. But I think there's a great opportunity for these patients to be, if you actually listen to everyone above 65, listen to their hearts, that actually you'll find that there's a lot of patients out in the community that may have varying degrees of aortic stenosis, but the ones that get to us have been appropriately sort of flagged and assessed and have come to us. But I think that's just the tip of the iceberg, as you've seen. And there's a real, the maturity of the interventions that we can offer. And if we can pick up these patients at wherever sort of wherever they are in the patient journey or the pathway, then we can actually put them into surveillance pathway or further assessment pathway or intervention pathway.
Right, thank you. Maybe we can move on. There are a couple more questions, but I think it would be good to get more information about the procedure, and then don't worry, those in the chat box, we'll get to your questions next, but it might be nice to
Sure.
go on if that's okay.
Sounds good. So as I said, in terms of the pathway, one of the key tests that we do, obviously apart from all the face-to-face things and talking to patients and assessing them clinically, is actually the CTE, and this has sort of really revolutionized our pathway. So this is, obviously we have CT scanners on every corner, and most of them are capable of doing a cardiac scan. So this is actually the aortic annulus of a patient that has bicuspid aortic valve with a sort of raphe. I don't know if you can see, I don't have a pointer there, but anyway, the big white blob in the middle of the right panel is a raphe between the three leaflets, the two leaflets. So it should be three leaflets. So essentially it's just a single orifice with bicuspid. So this is somebody that's actually will progress their valve much quicker, and they present much earlier. So we can see the anatomy. And we can size the valve itself. So there's obviously various different sizes, different companies, different sort of approaches. And this is the key, one of the key sort of tests to understand what's happening. We can also see a bit more of, so that's the same raphe. You can see that there's a lot of calcium there, and that's not going away. That's going to push onto something as we implant a valve. So we can actually plan, we can put simulated valves, we can do all sorts of things. So when I sort of started doing this in the early 2010s, we didn't have sort of robust CT sort of planning and so on. So that resulted in, and actually a lot of the early studies that we presented did not have access to sort of these mature planning techniques. So despite that, you see the results actually still very excellent versus medical therapy or also indeed surgery. So the planning is quite key, and you can look at the calcium. This sinotubular junction just above the coronary arteries. You can see there's calcium in the ascending aorta, and that might sort of change the plan. Some of the calcium actually extends into the left ventricle, so left ventricular outflow tract. So often, particularly depending on the type of valve that you're implanting, that can actually be quite hostile. And if you inflate, particularly a balloon expandable valve, that may cause annular injury. So one of the risks of our procedure is actually a tamponade, and sort of obviously the calcium is going to go somewhere. So, but we can plan quite accurately some of the risks. So that you can see the coronary heights. So we can see that the coronary heights are too low, or the sinus of Valsalva is too small. Then there's a risk of coronary obstruction, which is, can potentially be a catastrophic complication. But there's ways to sort of mitigate these risks by various maneuvers. But actually knowing that before you go in is actually quite important. We talked about simulated valves. You can actually see how everything works. You can put a valve in. So this is a 29 millimeter ring sizing, and they will tell you exactly where the leaflets may lie and so on. And we talked about the peripheral vasculature. So you can see this is the iliofemoral arteries, loss of calcium. Here, this is very suitable. So sizing in terms of, and the key thing is calcium. Some of the vessels could be quite heavily calcified, making it challenging, but we know that, and there's techniques where we can actually balloon the valves. There's lithotripsy, there's other things that we could do to try and get the technologies to the heart. And this is just a multi-planar reformatted iliofemoral artery. So it gives us a bit more information about sort of how it's all looking. Now, in terms of the procedure itself, this is one of the valves that we use for Medtronic. This is a self-expanding valve. This is used to be a lot more complicated when we sort of started doing this. So most of our patients now are having this procedure done under local anesthetic and sedation, so conscious sedation. They're awake. The procedure itself will take, from start to finish about 45 minutes, sometimes quicker, sometimes a bit longer. And this is a valve that's being expanded. The loop is a wire. It's quite a stiff wire that comes from the leg. There's a temporary wire just below it that's sort of bouncing around with sort of the dark tip that will allow you to sort of manage the heartbeat, heart rate. we tend to actually not put these in necessarily, but this has been one where there's a high risk that the patient was going to need a pacemaker. So as you can see, when you're expanding the valve, it can interfere with the pacing centers. But generally, we can actually pace on the left ventricular wire. So it's a very minimalist approach compared to what we were doing before that was under general anesthetic, sometimes with cardiopulmonary standby. Patients have got a transesophageal echocardiogram probe, they've got central lines, they've got urinary catheters. We've just done away with all these things, and actually our patients now can have a procedure while awake. They can actually be doing, and I have had patients doing crossword within about an hour or two of the procedure, I kid you not. And they're usually mobilizing the same day, and they're usually home the following day. So this is usually an overnight stay, and there's obviously sort of checks that will have an echocardiogram on the day if required, or on the table, and then they'll do sort of further checks the next day, and then they'll go home. So some of them that will need respite or rehab or all these things are facilitated. I mean, we've got all those sort of approaches available to us, and this is a valve that's deployed, almost deployed, so it's sort of 80% deployed, and you can see that we're just checking that the valve is in the right place. It's not too high, it's not too low, and this is a reasonable sort of position for this valve. You can see the coronary height at sort of 12 o'clock there. You can see my arrow, and then the final deployment. This is the Medtronic valve. This is how it looks. As I said, the patient's awake and they're ready to go. I've got to say, I mean, the team at Macquarie University Hospital is fantastic, particularly our, across the board actually, but our anaesthetists that make our procedures very simple, very straightforward, under conscious sedation, comfortable, which means that the patient recover quite a lot quicker. So obviously, a frail elderly patient going under general anaesthetic, even though it's a quick procedure, it's not as deep as a cardiac surgery or vascular sort of surgery. They recover much quicker. You can actually assess any complications sort of along the way. We talked about the stroke risk and so on, which is approaching about 1 to 2% for most of our patients. But if you're talking to the patient and moving everything, then you're quite comfortable that that's the sort of approach. And similarly, the rest of the team, the cardiac surgeons, the nurses, everyone is very adept, and all of these things. When you do high volumes of these procedures, then you get quite good at them, and the whole pathway, the coronary care unit, the recovery, the follow-up actually gets sort of much slicker. So the patients actually do very well. So I'm going to sort of stop there, and you potentially had some questions about the procedure there, Natasha?
Yeah, well, we have maybe some patient cases, and then we also do have one question regarding a patient who has both coronary artery disease requiring intervention and aortic stenosis, which I'm sure we'll see a lot. How do we approach that? Is it appropriate to have, interventions, or which interventions would you recommend?
Yeah, so we have this as a regular issue. So the patient would have had a coronary angiogram, they would have had a CT. All of these are generally reviewed. Our NBT, in fact, we had one sort of half an hour before we started actually. So we finished our NBT and we had exactly sort of these kind of patients, a patient with left main stenosis, mid-LAD disease, and severe aortic stenosis. And the patient was actually quite frail, had hematological issues and so on, and wanted to obviously avoid open heart surgery, and they had some platelet issues and so on. So the idea of actually putting in stents and committing them to aspirin and clopidogrel for sort of 6 months or even 3 months was not appropriate when we discussed it with the hematologist. So actually the decision for this patient was a robotic LEMA, so left internal mammary artery bypass, to the LAD, and then have a TAVI. So this is minimally invasive. They've not had a stenotomy, and we've got a fantastic team. Michael Wilson was on the call, and he'll be doing the procedure next week. So that patient is having a LEMA and then a TAVI, probably the same week. So there's others where you would actually put stents in the arteries and think about TAVI. And then the other option is a full surgical approach. So you'd have coronary bypass grafting as well as concomitant aorta valve replacement. and that's obviously very mature and so on. So these are options. They may have other disease in terms of, other valvular interventions that they need. So they may have mitral disease, tricuspid, and so on. So sometimes, surgery is actually the most efficient way. But in those that can't have surgery, or there's more appropriate to have an interventional approach, then we can offer that as well. But a hybrid approach of actually that one in particular, surgical, robotic minimally invasive bypass, and a TAVI, that's also appropriate. In terms of the evidence for coronary artery disease, this is actually an area that's been studied. Traditionally, we would actually just fix all the coronaries before doing the valve, and that's usually with stenting. But actually, a lot of I've been involved in one called activation, and we sort of randomize these patients to concomitant PCI before the TAVI versus no PCI, and actually we're surprised actually there's no difference. So we're actually a lot more relaxed about coronary disease in this. It seems that the valve is actually more important, but of course, if you've got very tight lesions, particularly in sort of big, important epicardial territories, then we should think about intervention and PCI. That'll be my approach. And if they're symptomatic, particularly with angina, of course, you can get angina from aortic valve stenosis, but often that could also be with. So if they've got symptoms, you want to be confident that you're improving their symptoms as well as the quality of life and a long-term trajectory. So if they're getting angina, then I would have a lower threshold for intervening.
Thanks for that. How urgent is it for patients to get a valve replacement or get a TAVI? One of the GPs here mentions that they had a patient who was getting quite frequent pre-syncopal events and unfortunately died prior to their cardiology review as an outpatient, and they were in and out of the hospital for several months. How quickly can we get these things done?
I'm sorry to hear that, and this is something that we sort of come up against. I mean, as you can see, sort of the burden of disease is huge, and in terms of this intervention, it was actually reimbursed and supported by the government in 2017. A whole probably 10 years, at least 7 years behind most of the Western world, I have to say. So we've not, although it's supported. So the biggest issue is in the public system. So most of our public hospitals, certainly New South Wales, we're not as good as our Victorian and Queensland colleagues. We're not getting the number of valves that we need. I mean, to give you an idea, it costs about $50,000 for one of these procedures. And in the public system, essentially you have a budget that's allocated to your hospital, and it's up to you to allocate, so you're competing against orthopedics and neurosurgery and other things for that budget. You're not getting extra budget for this particular procedure. Now, we have made some tracks, but at the moment in the public system, our waiting list is about 6 months. So we've got one of sort of the lowest sort of waiting lists, I have to say. But if somebody's unwell, we would actually just admit them to hospital and keep them in. So unless sort of there's other reason why you don't want to do the procedure, or you're going down a palliative pathway. So if we've got somebody that's bouncing in and out with pre-syncope, I think pre-syncope is one of the key ones. If it's got very high gradients, then I would advise patients to go straight to hospital, or at the next sign of a pre-syncope episode, I'll just say just call for an ambulance. So we should try and. I think some of the issue there is funding, unfortunately. In the private sector, it's less of an issue, and this has been sort of again sort of health fund supported. And of course, the hospitals, it's much cheaper for everyone if you're staying for an overnight stay, have a valve in your home versus a week in hospital, intensive care for 24 hours. Maybe rehab, and you might come back with bleeding, or you may have sort of other things. So that's been much more sort of straightforward, and it's I think a much easier pathway. Most of my patients would usually be admitted directly to hospital for their workup. So I may have seen in the clinic, or I may get one of my other cardiologist colleagues that say, look, this patient's symptomatic, they need TAVI. Often I can actually look at the images remotely, and we would get them in for an overnight stay for their workup. So all of that pathway, instead of multiple appointments with specialists, HK physician, cardiac surgeon, renal physician, and so on, they'll actually stay in overnight. They would have a coronary angiogram. They may have a CT the following day, assuming their kidneys are okay. and then everyone comes to them. They'll be seen by the anaesthetist, cardiac surgeon, aged care physician, our TAVI nurse coordinators that will actually coordinate all the things. They'll have the test, the echocardiogram, carotid ultrasound, lung function testing, all these things, overnight stay, and they usually go home. We would usually then put all the tests together. Our imaging colleagues, of course, we're supported by phenomenal imaging specialists that sort of produce all those imaging and so on. So we'll go through 10 to 15 cases in an hour, but all of that and all that planning and so on that goes into it is actually done sort of. So a lot of the cases would have been analysed. CTs are presented. We can actually look at. I mean, we've got sort of a lot of experience around the table, around the Zoom, and we can plan the procedure. So usually they'll go home. The second day, they usually discuss the following week, and if everything's suitable, they usually put on the list the week after that, essentially. So we're talking 2-week turnaround, but if somebody's actually critically unwell or we're worried, we'll just keep them in the hospital. So I do have a patient that's coming in this Thursday, coming in overnight stay, have their tests, and they're staying in hospital for the valve on the Tuesday, for example. So but that's somebody that I was actually very worried about. So I got a call from the cardiologist and said, look, this is, they are having pre-syncope. I'm worried about them. And I said, sure. I got the details, and the team organised for them to come in this week, and they'll stay in hospital and get their procedure done, and they'll be home. We can predict that they'll be home on Wednesday, Thursday. And so the pathway, I mean, it's been around a long time, and it's mature. So everyone's very au fait. Some of these patients are very complex, and having everyone around the table, I think, is very helpful. In terms of the procedural planning, a lot of it's happened beforehand. So, we may actually do, generally you would, in a cardiac theatre environment, you would do 2 open heart surgeries a day. So you do 1 in the morning, 1 in the afternoon. But we can get through 6 or 7 of these procedures a day. But the procedure itself is very straightforward. All the plannings happen, excellent anaesthetic team, perioperative team, and so on. So in terms of, that's the easy bit from my point of view, for sure. The hard bit is actually, getting the patients, addressing them in primary care, and actually, making sure that they're not sort of presenting late in the piece. And it is a sad issue, particularly in the public system, we're seeing, but we're much better than we were sort of 3 or 4 years ago, even. So I think there is light at the end of the tunnel. So if there are concerns, I think everyone's very approachable, and I think it's important sort of to be connected with your local cardiologist. And I'm sort of around, obviously, a few places in New South Wales. I'm very happy to be contacted, but we do take these patients very seriously, and we're here to help. Luckily, we're resourced to help these patients that are unwell and need to be sort of optimized quickly. So we just need that phone call, email, or otherwise.
Now, this is a hot topic. Will robotic procedures or AI be helpful for these interventions in the future?
Interesting. I think the short answer is yes. I think in terms of the obviously we looked at the risks. We quote sort of risks of 1 to 2% of anything serious. It's a risk of a heart attack, risk of death, the risk of stroke. We talked about coronary obstruction. There's lots of things that we can do, but I think because of the volume of procedures, we can actually upload all these things to the cloud and machine learning and so on. So where things have not gone so well, there may actually be things that we've not picked up. That of course I showed you the information that we have now is much more robust and detailed than we had when I first started training. But I think in the next sort of 5-10 years, for sure, that we're going to have sort of obviously better sort of diagnostics, better predictors of adverse outcomes, and simulated valves. We've got a whole suite of companies that sort of offer these valves. Obviously, it's a competitive market, and some are better than others in certain situations. So we may be able to predict better how the patient's going to do in terms of predicting whether somebody's going to need a pacemaker. There's things that we can predict just on some certain measurements around sort of the interventricular septum and membranous septum and so on, that we can actually predict that actually we need to land this valve within 1 millimeter of where it needs to go. And we can avoid a pacemaker, so we can reduce the pacemaker risk by 70-80% by just that information. the sort of in terms of actually, there's a lot of work in the surgical space. So the robotic space is actually fantastic, and actually, Michael Wilson, Professor Wilson, who works at Macquarie with us, does have a lot of energy in this space, and has actually got sort of 3D cameras around our procedures. So we've got a whole library of procedures that we've done in the past that we can actually log in and have a look. And similarly with his robotic program, all the cameras are occurring there and so on, and linked to sort of international database and so on, where actually with machine learning and so on, you can actually get maybe some prompts as to when you're doing a mitral valve repair, which is pretty complex robotically, that actually the anatomy could be assessed with AI, go into a whole database identified with 60, 70 procedures that have occurred in the world in this rare procedure, and you can actually have some prompts as to say, look, actually don't clip over here. You get the best outcome if you go across here, and so on. So it's pretty wild what's happening, and I'm glad sort of somebody brought it up. So I think it's an interesting time to be in the space.
The other question is about the alternative therapies, so medical therapies. One of the GPs mentions that she has a patient in her 90s with dementia, and she's very frail, and the family, doesn't really want any other interventions. What type of medical therapy would be available to her?
Yeah, so generally, and that's totally appropriate in certain individuals, and this is another conversation we have quite regularly with advanced dementia, renal failure, dialysis. Sometimes cancers, obviously cancer therapies have sort of massively advanced and so on. So our usual threshold for intervention is 1 year survival. So we think if somebody can survive beyond 1 year, that actually their quality of life and their outcome will be improved by treating the valve. If the prognosis is less than that, then we're less likely to sort of progress with that. In terms of medical therapy, so it depends on. It's usually symptom therapy. So often the patient may be in heart failure. They may so you can diurese them, you can optimize their blood pressure, you can obviously physiotherapy and occupational therapy within the home and so on. There is sort of, I guess, a halfway house where we can actually balloon the valve, and actually it's called balloon aortic valvuloplasty, is not an option we put out there. That potentially that could actually sort of buy time, particularly somebody who's very frail and not going to get through an operation or procedure. That could be an option. So in terms, it's generally managing their other risk factors, managing their quality of life, and trying to prevent falls, and correcting vision and other things, and keeping a close eye. So it's essentially, but actually you'd be surprised. I saw a patient last Friday that I've been looking after about 7 years, and had pretty bad dementia. It was falling probably about 5 years ago, and we decided to sort of go down a sort of a conservative pathway. She's got extremely high gradients. Her mobility is pretty low. She's got a 4-wheel walker now, but she's still happy. She's still alive. She walked in, and so on. So with sort of allied health and I think a multidisciplinary approach, I think we can actually get sort of obviously that's an unusual situation, and a lot of these patients are not surviving as long as that. So but we're here, we're treating those patients, and that's sort of broadly depends on the patient and the individual, and is supporting that individual and the family through that process.
Great, thank you so much for that. I think we might be coming to the end of this webinar, unless there's any more pressing questions that doctors would like to put in the chat box. I might just give a big thank you to... I
may just, before we finish,
I
may just summarize what we've gone through, if that's helpful.
Good, yeah.
And I think, I know we've not got much time, but I think just sort of actually summarize that actually untreated aortic stenosis that's symptomatic carries a very poor prognosis. There's a large burden of patients that are undiagnosed in the community. So I think this is where the real effort needs to be. And primary care is a big opportunity for these patients to be sort of discovered. So we should listen to the patient, auscultate, and then refer to an interventional cardiologist that has expertise in this area. Keep it simple with the examination as we went through. And ideally, you should be referring to a heart team or structural cardiologist that's actually got expertise in this area. And we have excellent outcomes with these patients using contemporary techniques that we sort of talked about. And contact details there. very happy to receive any comments, questions. If you're struggling with somebody, we're all connected and so on. So happy to sort of to help.
That's great. Thank you, Caleb. There's some comments in the chat box that if some of the doctors could get more of your contact info, more details about your contact info so they can refer to you. So
just screenshot and happy to help. And is the rest of the team.
Amazing. Thank you so much, Caleb. That was so informative and it was so fascinating, all the technological advances that have occurred to get us where we are in this space. So thank you so much. It was so informative and so helpful for us as GPs to know what we need to look for and what we need to pick up to help improve outcomes for our patients. So thank you so much. I really appreciate your time tonight.
Absolute pleasure. Enjoy the discussion.
Thank you.
I would like to extend my thanks to Caleb and Natasha for presenting this evening, and also everyone who joined us online. We hope you enjoyed the session and you also enjoy the rest of your evening. A friendly reminder that this is a CPD activity, and to receive your CPD hours, you must complete the survey following this webinar. The session is recorded, so if you have missed any parts of this webinar, the recording will be available on our CGP website within next week. That brings us to the end of the session. Thank you and good night, everyone.